Okay, so I think we are good. So hello, everyone who's watching. I'm Dr. Jess Daigle of Mom and Me by Jess Daigle MD, which is a fourth trimester postpartum care service designed to help moms and their babies adjust to home life after leaving the hospital. And one of the things that moms have to adjust to is the transition of having a new little person, especially a new mom at home. And that can bring on a lot of different emotions and issues, questions about who you are now and what's your role and how to still operate with this new person. And am I still who I am? And one of the challenges, other than dealing with having a new baby, a relationship, how your relationship is changing with your spouse, is sometimes those feelings can kind of creep up of dissatisfaction and concern and anxiety and even depression. And so that's why today I wanted to talk with Dr. Lucia Cheng, a perinatal psychiatrist, about postpartum depression and anxiety, and just kind of see what it is exactly for our viewers out there, and then just some of the challenges and questions that come up around this topic. So thank you, Dr. Chen, for being with me today. Please go ahead and introduce yourself.
Hello, happy to be here. Thank you for inviting me. So I'm Dr. Lucia Cheng. I'm a board certified psychiatrist specializing in perinatal and reproductive psychiatry. I'm currently in private practice doing telepsychiatry practice across 9 states. I'm a very active member with the Postpartum Support International Organization. If any of you guys don't know about that, it's an international organization specifically specializing in maternal mental health. They have a ton of resources, directory for providers, therapists, prescribers, as well as free online support groups. So if any of you guys don't know about that, feel free to check that out. Recommend it to your friends and family and patients. So yeah, I'm happy to be here and, open to answering any questions about perinatal psychiatry you've got.
Yeah, so one of the questions is if you can just kind of give your definition of postpartum depression. And the reason I say that is because it used to just be isolated to just depression, but it's actually now grouped into like mood disorders, correct?
Yes.
And so can you speak to a little bit about that? Like, what's that spectrum, or if it is considered a spectrum?
So it is on a bit of a spectrum. There's a whole series of now what we've specified as postpartum mood and anxiety disorder. We call it PMADS. So it stands for perinatal mood anxiety disorder. And it helps to kind of give a better encompassing view of all the various postpartum and perinatal mood disorders and anxiety disorders, because they very often come together. And a lot of the times the symptoms actually start before postpartum. They actually start in pregnancy, but it's all due to the same effects, the hormone shifts, the psychological aspects of anxiety and fear about being a parent. Sometimes there's a lot of trauma issues involved because pregnancy and birth tends to trigger a lot of trauma for a lot of women in the past. And so PMADS is kind of encompassing the whole spectrum, but it is a spectrum for the mildest and lightest, and what you hear about the most often is postpartum blues. And that's really, it's a very short lasting period, generally within the first 2 weeks immediately postpartum, where people just feel off. They're moody, they're depressed, they're emotionally reactive, they get upset very easily, they're irritable, they're not sleeping well. And that's due to just the immediate postpartum hormone shifts, because there's a lot of hormone changes going on and a lot of fluid shifting. They just lost a lot of blood, they lost a lot of fluid, their prolactin is going through the roof to induce the breast milk production. And so just that chemical adjustment tends to cause a lot of mood changes, anxiety symptoms, sleep disruption, etc. But those are considered, just normal. Unfortunately, is how our body reacts to the hormone changes. And they're self-limited. They're usually gone by about 2 weeks. And usually they're fairly mild for most women. It's uncomfortable and it does hamper them from being fully productive, but it's not debilitating.
Okay.
And so it should never be that severe. There should never be any suicidal thoughts. There should never be any, insomnia so severe that they're staying up for days and days at a row, that kind of stuff. And so the mild form and time-limited form, we basically consider to be postpartum blues. We don't really diagnose anything more severe unless there's more severe symptoms during that period. But if it lasts more than 2 weeks, that's when we start looking and assessing for postpartum depression, because then that means that we're looking at a longer lasting picture, likely more severe and chronic symptoms. And then we want to look at making sure that we treat early if possible.
Okay, so you can start off with blues and it can just end there, but if it's going longer than a few weeks and then you're starting to have some intrusive thoughts and debilitating, meaning you just really can't function, just like when people are diagnosed with regular depression, like not eating, not sleeping, not wanting to do any activities, feeling like they can't really connect with the baby, things like that, they need to kind of start to seek help at that time. So how do you differentiate that from postpartum anxiety? Like if, and especially when already you're anxious because especially a new mom who doesn't know a lot about taking care of a baby, and they're really concerned about everything, like they want to make sure that they're doing right by their baby. So how do they know when it's just normal, like I just don't know what I'm doing and I'm trying to learn, versus like it's overtaking me, like I just can't, I'm just feeling so anxious all the time that I can barely do anything.
So really the main defining characteristics of anxiety versus depression is worry.
Okay.
And if they're constantly concerned or worried, and that could lead to behaviors as a result of the worry, such as they start tracking things much more carefully. They're writing, they're tracking how much food the baby is eating at what time, exactly what amounts, what temperatures, how much the baby is pooping, how many diapers, usually that comes out in the form of monitoring and tracking, kind of obsessively. And, an inability to relax.
Okay.
Depression tends to be more of a energy drain. And so people who are depressed, they really struggle to get out of bed. They really struggle to get motivated to do things. They don't feel able to engage in activities and behaviors. They're thinking very negative thoughts about themselves and their abilities. And so it's more of a dragging down type of feeling for people with depression versus anxiety is I'm worried. I'm worried about this. I'm worried about that. I can't relax because I'm constantly worried about these things. And what if I do something wrong? And so it's more something in my action or something about me that is causing issues for my baby or for the family, etc. So, those are kind of the main differentiations.
Okay, that's good. And that's actually really helpful, especially for our moms who will watch this too. And if you end up watching this later, definitely put hashtag replay and let us know still if you have questions. We can always still answer those later because we are in the middle of the day. So some people may have to catch this later. But when a mom is having these symptoms and things I know that we have a scale for asking moms for diagnosing for depression. Is it the same one we use for anxiety? Will it tease out both, or will the mom just have to come and share like her experience and then the OB is able to figure out which pathway she needs to go?
So the most commonly known scale for postpartum depression is the Edinburgh Postpartum Depression Scale, the EPDS. Most people have heard about that. It's a very easy to administer. It's a validated scale, and it picks up postpartum depression quite well. There's a few questions, about 3 or 4 questions in there that are also very useful for picking up anxiety.
Okay.
And once again, they run together very often. And so just because you have anxiety doesn't mean you don't have depression, and vice versa. And sometimes they run together. But if you have somebody who, are scoring much higher on the anxiety questions and much lower on the depression, that does help you tease out a little bit about, that this is anxiety as opposed to depression. Now that scale, even though it says it's postpartum, it actually is usable for prenatal as well.
Okay.
So during pregnancy, like, I mentioned before, a lot of symptoms actually start during pregnancy, not postpartum. And so that is a good way to be screening for pregnant women as well and catching it early so that it doesn't get worse postpartum.
I'll have to ask, because, obviously I work with the families after they've had the baby. I wonder, do you even know, is it typical for OBs to like start to do some prenatal screening? Or do you think that's something we should be kind of starting to do as routine?
Well, the difficulty with OBs is they have so much on their plate. And
Mhm.
every time they do their prenatal visits, they have a limited amount of time with these
That's true.
patients. And, there's other things that they really worry about,
Yeah, like
like the
the
baby's
growth.
size, the baby's health, the umbilical cord, the placenta,
Yeah,
amniotic sac, all that.
yeah,
And so, a lot of them may not necessarily have the time, or it doesn't that just kind of rank high enough. And sometimes the women don't say anything because they feel
that's true.
embarrassed, or they feel like, I don't want to give my doctor the wrong idea. I do want this baby, but I'm so depressed. I don't want the doctor to think I don't want this baby. And,
Yeah.
all that. There's a lot of shame as well. And so it doesn't get picked up as often as we would like to see it picked up. But some OBs, they're more informed about the mental health aspect. And so they do. And also, it's also some states' policy that screening is required at various stages of pregnancy and postpartum. And so
Good
in
to
those
know.
states, I think it does get picked up more often.
I'm gonna have to check on, because I'm in Georgia, I'm gonna have to check on Georgia's like policy and just kind of ask our OBs, like in my local hospital. So since we know that it is, can be come up prenatally, and we should probably be screening, do you recommend like that every mom, I guess outside of screening, should they engage in like any type of counseling or therapy as part of like their postpartum plan?
Absolutely. I always tell people therapy is not just for when you're struggling, because therapy can also help you to refine and improve coping skills, stress management skills, just learning more about your style of doing various things, in a perinatal situation. Sometimes moms, they don't really understand what their style of parenting is, and getting some insight into how they respond best to certain types of input can be really helpful in them bonding with their babies and caring for their babies afterwards, or how they interact with their family members as far as asking for help. Some women, they're coming from high powered careers and they're not used to needing help. And then they have this baby and they're tired and physically they're drained. And all of a sudden it's like, I can't do it on my own. But they never learned how to ask for help from others. And that's also a very important skill when you're parenting for the first time. So.
Yeah, and that's a stressor. And that's funny because I think one of my friends is doing a talk. It might be later on today or Monday or so about with a coach that talks about the should, like that word, like
Mhm.
what you should be doing and how you should be doing things. It really gets us into a lot of trouble because that's already added pressure. I had a mom one time in the hospital. She was a new mom and she was breastfeeding, and we're working on our like education, like standardizing what our nurses say to parents
Mhm.
and things like that, because that also can be a sense of stress. So you're already trying to do something that's very hard,
Mhm.
right? And that's a whole nother thing about perception and all that too, right?
Yeah.
But she hadn't like woken the baby up to feed or something, and she was like crying in real distress. And she was like, I should have like known. And I asked her, I was like, well, why do you think you should have known
Mhm.
what to do? And then she paused and kind of thought about it. Like, that's true. Like, why would you know that? It's not something you've done before. You can't know what to do about something you've never done before. And so that's one of my passions, is with educating, to let them know what's possible, what's typical. But I don't even like to put people into a box. I always say we fall on the spectrum, like the bell-shaped curve is what I like to say. Like, a lot of people be in the middle, but you always have outliers, and it doesn't necessarily mean that that baby is more or less right or wrong. It's
Mhm.
using objective things like weight and wet diapers and other things to see, okay, is this baby, growing well and things like that. So I think that's really good, neat that you pointed that out, that is one of the biggest things
Mhm.
that should be doing. Well, this is all so good. It's some stuff that I didn't even really know. And that's really good about the therapy piece too. And adding that in along with that prenatal, they could even start early identifying, like you said, the style of parenting. And even me as a mom, I never really thought about it until I had kids right in the midst of it, and you're right. Like, you either do two things: you either parent like how you were parented, or you don't like it. And so then you try a different way, but still that way is not necessarily proven. I say being a parent is on the job training.
Exactly, exactly. And
Because
and a lot of people, they had maybe difficulties with their parents. growing up. And that may be something that they're struggling with internally as far as what kind of parent am I going to be? You know, I had a really hard time with my parents. I don't want to put my kids through that, but I don't know how to parent any other way.
That's
And,
true.
you know, this is why I really want to give another plug for the PSI organization, because they have a training and certification process for their therapists. So they have a directory of PMH certified, so perinatal mental health certified therapists who receive special education and training to, you know, address all the different aspects of things that can come up in a, you know, pregnant, mothering, new parent, postpartum situation. And so those therapists, I think, are particularly helpful when you're dealing with, you know, the perinatal period, because they will even actually help address and head off problems that people don't see coming.
Yeah, and I've actually joined that organization, and I'm looking into some extra training too, especially in the work that I want to do. I want to make sure that I'm most effective at helping my moms too, and identifying who is on that struggle, that to kind of capture early, like almost like preventative
Yes.
type of care. That's good. Let's see if there's anybody that had any questions. Otherwise, I didn't see anything else here. Let's see if there was one more. Okay, so one of the things that has come up too, when people do start, okay, so they go to their OB, who often refers you to a, well, before I get to that, can you kind of differentiate the difference between like what a counselor, therapist, and then a psychiatrist will do for a family, like how they might walk that path? So they go to their OB, and their OB does the screening and find that there's some concern. Should they automatically send them straight to a psychiatrist, or is there a step where they should go to a therapist or counselor first before heading to a psychiatrist?
So it really depends on the situation and the patient's history. You know, as counselors and therapists, they do psychotherapy, talk therapy. They don't prescribe generally in most states. Whereas the psychiatrists we're medical doctors, and so we do medication management. A lot of us in private practice also do psychotherapy, but it depends. Most of it, you know, we definitely do medication management. Some of us do that psychotherapy if we have the time. And so it really depends on what the situation is of the patient going into that. For example, like some OBs, you know, if they are comfortable and feel that the patient needs an antidepressant or something to treat the anxiety, they may start the medication, but then say, I don't really feel comfortable managing this, you know, long term. So their first referral may be to a psychiatrist, because this patient already needs medication management. If the OB feels, well, your symptoms are pretty mild, maybe you can just, you know, talk to a therapist and see if that gets better and go from there. Then, you know, if they're not starting medications, or if the patient isn't already on psychiatric medications that they're concerned about, because some moms, they're already on antidepressants or anti-anxiety medications for pre-existing condition. But, you know, if the OB feels, well, you know, maybe some therapy will help, they will start off referring to a therapist.
That's good. That's good. And so you kind of mentioned something there, which was one of my other questions. So if someone is already have a history of diagnosis of depression or bipolar disorder, anxiety, are they at a higher risk for postpartum depression and for PMAD?
Absolutely. The single highest risk factor for postpartum depression and anxiety is a pre-existing depression and anxiety disorder.
So that's something good too that an OB could use. Like if they know that there's history, they can already get ahead of it too. And even during the pregnancy, say, hey, suggest you meet with the therapist and or psychiatrist to kind of make sure that your mood is being maintained properly during the pregnancy and things like that. And I'm also part of the Postpartum Support International Facebook group. And I see a lot of moms, a lot of times struggling too with the medical management, like kind of frustrated with how long it takes for medications to start, and then trying to decide when do they need to just give it more time, or when it's not working. Can you speak to that process? Like just how would you suggest a mom kind of get through that? Like if they're started on something, but they're still experiencing some symptoms, how long they should wait typically before they worry that it's not effective enough?
So, you know, first line treatment for both depression and anxiety is an SSRI antidepressant.
Okay.
And SSRI, you know, that class includes, you know, Prozac, Zoloft, Lexapro, Celexa. We don't use Paxil very much anymore in women, but that class of medications, it's safe, it's effective, it's got the best pregnancy and breastfeeding safety data of all the classes of psychiatric medications.
Okay.
We know it very well, but it can take about 4 to 6 weeks for it to start working. And the difficulty with that class is the side effects will hit during the first month, and then they go away, and then the med starts to take effect.
So you kind of,
yeah, and you lose a lot of people in that first month because they're thinking, I don't feel any better, and I'm having these side effects. This med sucks. And so they stop taking you, or they ask for something else. But we don't consider that a med has had an adequate trial until you have been on it for at least 4 to 6 weeks. And so if you stop it too early and you come and see another psychiatrist and say, I tried that med, I took it for a week and a half, it was horrible, I didn't like it. I was like, well, you didn't really give it a chance.
Yeah. And then it would be like, that's probably most of the medication, right? So even if someone was to put you on something else, then you still have to give that some time.
Exactly.
And then you kind of lost ground with the medication that probably would have worked.
And you're actually losing more time because you keep jumping from med to med. But with every new med trial, you got to give it 4 to 6 weeks.
Yeah. And then you're getting more and more anxious. And then so you kind of end up in a cycle.
So some patience is needed initially with medication.
Yeah. So one of the things too that I've seen come up with, it was one of my colleagues had posted about a physician who had died by suicide from like perinatal postpartum psychosis. So can you speak a little bit to that? Like how like, I guess often if the other ones are on a spectrum, is that also in that same spectrum of the PMAS, or is that in a different class of its own?
So that is still in a bit of a gray area. We're actually actively doing research on postpartum psychosis right now. Mass General Hospital, they have a Center for Women's Mental Health department. Some of the foremost perinatal psychiatrists are on staff there, and they hold probably one of the largest medication, pregnancy, and breastfeeding safety data registries in the world as well. So they're actively doing a lot of research. If you have any moms with postpartum psychosis, I strongly recommend that you send them as to that website and to that group so that we can collect more data. But
posted in the Facebook later.
Yeah, we actually don't have a fantastic understanding of postpartum psychosis yet. We don't know what's triggering it, what the chemical mechanisms are, how the interplay between the neurotransmitters and the reproductive hormones are. But what we have found is that, first of all, it's quite rare. You hear a lot of fear about postpartum psychosis, and that often gets confused with postpartum OCD. And so it's important not to confuse those two because they're very different things. But postpartum psychosis, it is very rare. However, it is very dangerous, and we do consider it a psychiatric emergency. What we're looking for is disconnection from reality. They no longer are reality based. Like OCD, they have a lot of very disturbing thoughts, but they know what is real and what isn't, and they recognize that those disturbing thoughts are not actually real. They just can't get rid of them. Whereas postpartum psychosis, they really do believe these weird delusional thoughts, and they start acting according to that delusional worldview, and that's where the danger is. And all those legal cases that you've heard about moms killing their babies or killing their children, the vast majority of those are due to postpartum psychosis that went unrecognized and untreated. And postpartum psychosis, what we have found is there's a very high link between postpartum psychosis and bipolar disorder, whether diagnosed or undiagnosed. And sometimes postpartum psychosis is the first exhibition of the symptoms of bipolar disorder. And then after that, we recognize that, oh, this person actually has had bipolar type symptoms, extremely mild in the past, but this is the first major blow up with their bipolar disorder. And so we consider somebody who's had an episode of postpartum psychosis to be bipolar disorder unless otherwise proven. And we treat as such.
So it makes me wonder, like, how can you even capture those women? Like, it's really going to just be down to educating the masses, right? Like, so people in someone's family can be like, they're displaying this type of behavior, I suggest they go and talk with someone or be seen. And because there's really no like screening for bipolar disorder, right?
No, and we don't expect OBs or, pediatricians
Yeah,
to
I know.
know
It's
how
just
to do that.
interesting. Yeah.
But, that really highlights the importance of listening to family members. Because
Mhm.
usually what happens is family members will come in and say, she's acting a little odd. Like she doesn't do this normally,
Okay.
And then when they say something like that, really follow it, tease it out a
Yeah.
little bit more. But what do you
Yeah.
mean by that? What is she doing that isn't normal for her?
Mhm.
And and then talk to the patient some more, ask about those behaviors, and if some of the things that the patient's saying is just like that doesn't really sound right,
Yeah.
that's when you may want to send in to a psychiatrist. And
Okay.
this is not a therapy issue. Therapists cannot do much with this. This
Yeah.
is a psychiatry issue because potentially it's a psychiatric emergency, so those people
Yeah.
really need to be evaluated.
Okay. This is also good because I mean, and I definitely don't mean to say that a OB should or a PEDS should. I'm just trying to get to like who, we're the ones that see them the most, to be honest,
Yeah.
and outside of like their primary care doctor. But even me, like I went to my OB appointments more faithfully than I did my regular my regular checkups, to be honest. I'm one of those bad doctor patients. But so, like that would have been the person who probably would have seen me the most. So that's what I mean. So, definitely don't want to burden anyone else more with any more like screenings. But that being said, it's so important. So finding some type of way. I know like even at my pediatrician office, he still was asking us doing like the Edinburgh, and even way into my daughter was like, I think 3 months, I was still having to answer questions about my mood and, like trying to tease out if I was dealing with postpartum depression. So I really appreciated that. And I hadn't even recalled doing that in training myself. So I don't know if that was something that was fairly recent, because I don't even remember that happening with my son. And he's like 8 now, but my daughter's 3. And like 3 years ago, he was having me fill this out. So I definitely think it does help in some capacity, even if it's just starting with something that a form or something that the moms can start to kind of answer some questions that can kind of raise that flag. And so this has been so helpful. Thank you. And I just have one last question that I know, because I did a live video talking about that, hey, did you know there's postpartum depression that can happen in men or the partners or spouses? And that was new to me. Like it had never occurred to me that the dad or spouse or partner, or basically probably anybody connected to the mom in the home could also deal with depression and anxiety after having a baby. So can you speak to a little bit about that? Like when does that typically seem to show up, and how it's kind of can be connected to postpartum depression in the moms?
Sure. It's actually pretty common. Granted, it's even less well studied than postpartum depression in moms, understandably, because then, we're focusing on the moms and not really recognizing the dads so much, or, partners. It doesn't have to be a father. It could be any partner. But it generally, from what we know so far, it can occur in about 10 to 15% of partners. So, fairly high rate when you consider postpartum depression is about 15 to 20% of women. So, getting up there. And they can present with a lot of the same symptoms of both depression and anxiety. Of course, the risk is higher if that partner has had a previous history of a mood or anxiety disorder as well. So same risk factors, same type of symptoms that you look for. Treatment generally is the same, although with partner postpartum depression and anxiety, we do tend to recommend starting with psychotherapy first, because even though the partners, there is evidence to show that they do have some hormone shifts as well during the postpartum period, they're generally not as severe as a woman who actually has just birthed a baby, just because the biological, so the biochemical disruption is on a much lower scale than it would be for a birthing person. So therapy usually can do the trick for most partner postpartum depression and anxiety. Interestingly, the EPDS that we mentioned, there is a partner version of that test. So it's the EPDS-partner, and that can be used to assess a partner.
Wow. Look at that. That's so good. Well, tell people how they can find you if they want to know more information or work with you.
Yes, so like I said, I have a telepsychiatry private practice in 9 states. So Alaska, Arizona, California, Florida, Illinois, Michigan, New Mexico, Ohio, and Texas. And I'm in the process of getting licensed from Missouri and Minnesota.
And
So
you're going to have to add Georgia to that list, okay?
working on it, working on it. I have to, I can't
Yeah,
expect it.
no,
It's a
the
lot of
licensing is a
licensing
lot.
fees I
Yes.
have to pay.
They need to come up with some kind of program where it's like they do for the nurses, where it's like all.
Yeah, I know. Well, there is
They-
the interstate medical licensing compact, but it's only covering, I think, like 29 states so far. And
Oh,
a lot of states are not part of that.
right.
But I am taking new patients. I am private pay. I'm out of network, but I do provide a super bill. My rates are very reasonable. It's currently $300 for a new patient eval, $150
Okay.
for a follow-up appointment. I do primarily med management. And the easiest way to learn more about me and my practice is through my website. So it's Phoenix Progressive Psychiatric Services. So it's PPPS and then my initials LC, Lucia Cheng. So PPPSLC.com.
Okay, and I'll post it in the comments.
Okay.
Yeah.
And yeah, I'm also board certified in lifestyle medicine. And so I do very strongly focus on making lifestyle improvements in the form of, diet, sleep, exercise. And I'm not pushing medications very heavily generally, really only as needed. But I really want to help women to be able to improve their whole body experience in general.
Good.
So yeah, happy to take any referrals. Thank you.
Yeah. And do you end up using some of that in helping these moms during the postpartum too? Is what you mean when you say when you do the lifestyle medicine, does that tend to be able to help the moms?
Yeah, I do. When I do my psychiatric assessments, I do also assess the diet. I assess the sleep. I'm very focused on sleep because people underestimate how important sleep is in mental and physical health.
Yeah.
And so I really work very hard to help moms, and especially with a new baby, it's really hard to regulate.
It is because you're breastfeeding around the clock and
causes a lot of disruption.
And it's interrupted.
Yeah, and so I work very hard with mom to kind of figure out a plan for the sleep so that they're able to get adequate rest. And then I talk a lot about the benefits of exercise. I try to use more natural and holistic ways of treating certain symptoms rather than going straight to medication, but I will use medication if necessary.
Getting there. That's good. So I'll post that in the links, and I'm Dr. Just Daigle of Mom and Me. And if you want help in your 4th trimester as well, I'll also post my Calendly link, and you can have a free 30 meet and greet with me and see how I can help you during that time as well. I mean, like I said, motherhood is on the job training, and we want to do all we can to take care of our moms. Because taking care of you, mom, is how you can best take care of your baby and your family. It's reciprocal, and you can't have one without the other. And that's one of the things that I want to do is kind of we want to revolutionize that postpartum care and really get it to be the best that it can be for our moms and stuff. So thank you, Dr. Lucia Cheng. I have learned so much today. I really have, because I mean, we scratched a lot, and probably barely the surface, but especially knowing about the trainings and that there's a tool for the dads or partner, and how best to the differences between the therapist and what the psychiatrist can do. Because sometimes I've seen where people are a little bit frustrated, like I went to the therapist but they only can do so much, and the psychiatrist, so they kind of have to work in concert together. And like you said, more of the mindset and working through how to plan to have your best postpartum experience. So I hope that you have a great rest of your day and weekend, and I hope that we'll be able to collaborate again sometime.
Absolutely. You have a wonderful day too. Thank you so much.
All right. And thank you to all of our viewers. Bye.
Bye-bye.